Merci. Bonjour. That's about it from me as well. I just wanted to say thank you very much, really, to all of you, for, particularly to Roman, for asking me to be here. It's a real privilege and an honour to be with such a big group of people. I'm particularly passionate about the subject I'm going to talk to you about today, about developing evidence-based practice and guidance for people working in what we call forensic settings. It's been a very long and interesting journey for myself, and it's created lots of opportunities and challenges for me. So, oh, that's my thank you slide. Sorry, I need to move on. Thank you again. So I just thought I'd tell you a little bit about where I work at the moment. So I do have a funny job. I work across 2 universities and we have a joint faculty. So I work in a medical school and I also work in a school which is called Health and Social Care. And so I'm not sure I'm going to get the hang of this going down like this. So I'm currently the programme lead for occupational therapy. I'm also chair of the Royal College Specialist Section for Mental Health, and I'm a Forensic Forum member. I'm in a number of research groups related to mental health, a couple of international ones. But I guess the main thing for me is that I'm passionate about the value and contribution of occupational therapy in forensic mental health. And it's the sort of last thing that's really promoted my journey or pushed me along my journey. So prior to working in, I've got to keep going down here. I feel like I'm going to miss something. So prior to coming into working in a university, I worked at Broadmoor Hospital, which you can see on the left there. It's one of our biggest high secure hospitals in the UK. And I've also worked in medium secure hospitals. You can see how big it is. It's a huge hospital when I first started working there. And on the right, you can see the kind of patient environment, which is really sparse. And people had, in those days, when I first started working there, people had very little personal items. They weren't allowed much. And if they were in seclusion, do you have the concept of seclusion here? Yeah, so if they were in seclusion or they were being nursed in a segregated way from the rest of the ward, they would very often have nothing. And those were the people that really concerned me, the kind of patients that were really occupationally deprived. And in those early days in forensic services, what tended to happen was patients were offered things to do. I'm off script a little bit now. Patients were offered things to do, but it was often things that were available within the environment or that the staff liked doing. So they weren't being offered those meaningful things that might be relevant to them. And in some cases, they couldn't be offered those because they were very criminal activities. And as occupational therapists, we can't offer those criminal activities. We have to do those pro-social things, as much as I'd quite like to learn how to steal a car and things like that. But I think we've moved. I think as a forensic community, I think we have moved from that. So I just thought I'd tell you a little bit. I don't know how much you know about secure hospitals in the UK, but what we have is we have a system of high secure, medium, low, and then we have our community specialist teams. We have approximately 7,000 to 8,000 beds across the UK, and that can be state beds, or we have a lot of privately funded beds. So we have a lot of private hospitals in the UK that offer secure settings. Now, I've kind of costed it in pounds and euros and not in Swiss francs, so I'm very sorry about that. Anyway, it costs anything between 189,000 euros to 344,000 euros per year per patient. So that's a huge cost for people. And what we're trying to do in the UK is keep people in secure hospitals for as short a time as possible. You know, the typical stay now is something like 2 to 5 years, whereas before it would have been something like 10 plus years. People can be transferred from prisons and from other hospitals, so they might go in and out of these settings. Do you have something like the Mental Health Act here, where people can be deprived legally of their liberty? So you do have the same thing. And people can't be discharged can't be discharged unless there's specific permission from the Ministry of Justice very often for those on particular sections. But kind of linking with Ulrika's presentation, the current trend now is more on not thinking just about the disease, illness and what the person may have done in terms of leading them into a secure hospital, but more on recovery. So how are we going to help that person recover? How are we going to help that person achieve the life that they want to achieve and the meaning and the occupational identity that they want to have, rather than being disease-focused? And we have a much more emphasis now on patient involvement. So something, again, as Ulrika was saying, so peer involvement, but we have patients who've been in secure settings who are involved in the development of services now, who are on national committees. So there's a guy called Ian Callaghan, who is kind of our national service user lead. So there's much more focus on what the person wants from services as well. So some of you may know this, but I thought it might be helpful to say that in terms of where we are in the UK, occupational therapy in secure environments, we're a core part of the service provision. Every hospital, every team, every ward-based team will have an occupational therapist, as well as social workers, psychologists, nurses, and various other people. Patients have a personalised plan, which is made out of their therapeutic and skill developing activities. It's related to where they finally want to go, and there is a connection between the activities that they do within the hospital setting and the achievement of their recovery goals. And again, that's quite different to how it was much earlier. And we are occupation-based, as we would be in terms of occupational therapists. So we're looking at people's interpersonal skills, their life skills, trying to encourage people to what we call those pro-social occupations, so trying to move them away from those criminal activities that they might prefer and they might earn a lot of money from, but it does get them back in and out of prison and into the hospital. We also want to help people develop occupational identities, but in the way that they wish to do so. And I'm sure I don't need to tell you that our focus is on health, wellbeing, participation, and the person, environment, occupation, participation links. So what sparked my desire to kind of think about occupational deprivation was my starting points were that I could see that there were limited opportunities for patients' occupational engagement. So, you know, what they really wanted to do, what really mattered to them, what really gave them some, you know, a buzz out of life. I was also very interested because at this point I was becoming an occupational scientist as well as an occupational therapist. So I'm going to hold my hand up. I've got two identities now. But I was also very interested on the impact of occupational deprivation, not only within the immediate environment, but how that had impacted on people's lives before they got into hospital. The sort of histories that people came with, their very impoverished lives and lack of occupational opportunities. I think as institutions, we de-skill our patients very often. And I'm very encouraged by the link between occupation, well-being, the concept of flow and self-belief. But I also had to recognise that working in a forensic setting, you can't just take a patient where you want to. You can't just do what a patient wants to do because of the environmental and legal constraints. You are very much restricted by what you can offer and where you can offer it at times. The other thing that we do need to think about is that we have got a growing older population in forensic settings now. Some of our patients have been there for a very, very long time and are growing old within those settings, and so there are some age and comorbidity related problems. So I'm not going to really go over occupational deprivation too much because Ulrika's already done that, and it's useful sitting in on somebody's presentation when you do your own because you kind of know. But I think you took us through the Wilcock and the Gail Whiteford references. But there's a really, if any of you are interested, there's a really good paper that from Occupational Therapy Australia, which is relatively new, but it kind of really talks about occupational deprivation is just not just a personal thing, it's really to do with, it can be physical environments, it can be social, it can be attitudinal, some of the things that Ulrika's already said, that discriminatory stigma stuff. As professionals, we can also deprive people of their occupations. There's racial, there's legislative, and there's some political impediments to participation in occupations. So there's some more definitions there, which I guess the point that I want to make in terms of forensic environments is that we deprive people of their true occupational choices. Sometimes that's because we have no choice ourselves, because some of the things that they want to do. I remember being a very naive forensic occupational therapist and doing a survey of what the patients wanted to do when I first got there. And they wanted to do things like whitewater rafting and wall climbing and things. And it was like, oh, God, how are we going to manage to be able to provide this? Wall climbing, they might try and escape. Whitewater rafting, well, we haven't got anywhere we can take them. And it was kind of like I'd set myself up being very naive, so I kind of never would do that again. But we did get some interesting ideas as well, and we did think about those things. But, it was really hard in those first early days. So in our first early days, I'm taking a real step back in time now. When I was working in a medium secure hospital, we, as a group of therapists, wanted to underpin our practice more theoretically. And we decided at that time that occupational science had much to offer. So my colleague, Matthew Molyneux, who some of you may have read about, I have to say he's probably the most influential person in my career, in my life. And Mandy Lang, who's the other most influential person. Those two people and myself developed this framework that you can see up here. Oh, now how do I get the... Oh, yes, here. Right, oh, now I'm probably going to forget how to do all this, so I can't multitask. But what we wanted to try and do was to put a framework together for ourselves as an occupational therapy team, but also to try and help the rest of the team, particularly some of the psychiatrists that we were working with at the time. Are there any psychiatrists in the room? No. But we wanted to put together a framework to help us understand. So in the middle, you'll see that you've got the person, the homo occupatio. That's the person who is somebody who makes choices, set goals, is competent by engaging in occupation. And as occupational beings, we're designed to do, and a lot of our patients at the time weren't doing very much at all. Obviously, yes, there you can see performance deficits. I don't need to tell you that people with mental health problems do have performance deficits at times, and that can be related to their illnesses and the symptoms of their illnesses. A lot of people had occupational imbalance, so they weren't doing very much on the ward. They were just spending a lot of time sleeping. They didn't really want to engage in activities because the things that were being offered weren't really of interest to them. Or if people were in a manic episode, so if they had bipolar affective disorder, they were doing loads and loads and loads of things and very, very busy and trying to occupy themselves all the time, which is equally not very good for them. There were people that had this sense of occupational alienation. Have you heard of that? Where people are alienated from their sense of community. Now, they may have been alienated in their very early lives because of their lives that they had with their families. They may not have been able to engage in occupations and those sort of things. And they may have been alienated on the wards. And that may be due to the crime that they have committed, so that there are certain crimes in forensic services that are completely unacceptable to other people. You know, particularly if children are involved, those kind of things. And so those patients can get alienated if it gets known what they've done. And yet there are other crimes that are much more kind of like high. They're on the, oh, it's okay to have done that, you know, to somebody. Like, I worked with somebody who wanted to kill the Prime Minister at one point. Now, everybody thought that that person was great, you know, and people that had done things to the police and things like that, everybody thought they were great as well. But, you know, I'm not saying, I'm not an agent of the state, but I'm not, you know, that there is a definite, things are okay and things are not. So they can be alienated by their crimes. They can have occupational disruption, which is the temporary disruption of the occupations that they wish to engage in. And then there is obviously occupational deprivation, which was one of our main focuses. And they may have been deprived in their early lives through lots of things, through no fault of their own, but all the sort of things that we've already gone through. Now, some of us can experience all those things and still function and still get on with our lives and not resort to criminal activities. Yeah, would you agree? Some of us. Whereas some people, these things do affect us in such a way that we become dysfunctional, that we can't perform in the way that we might need to or want to. And then what we were thinking was that there was possibly an increase in people's risks or offending behaviour. So that was kind of what we were proffering as a not as a theory as such, because that's too strong a word, but as a way of thinking about the people that we were working with. And so what we wanted to help people focus on, particularly some of our technical staff and our assistants, was trying to enrich people's occupational lives and through the process and the outcome of treatment. So, I now need to go back down here. So I was fortunate enough, after having worked there, to be able to register for a PhD study. And I have a particular interest in working with people with personality disorders in forensic settings, because at that early time, when I started my PhD, they were a group that people really didn't want to think about because of the kind of challenges that people can pose and can... they can challenge a professional team in terms of what they want and what they think they want and how they think treatment should be. So I had a particular interest in that. And so what I wanted to do was I wanted to explore the experiences of this group of men in secure settings, but taking the perspectives of the men themselves, because I thought that was really important. Look at what the managers felt was happening in terms of occupational therapy practice, but then look at the occupational therapists themselves. And so I used a qualitative research study using, when I'm anxious, I can't say interpretive phenomenological analysis very well, so you have to bear with me, just read it. And I had 2 high and 2 medium secure hospitals in the UK. I had to have all sorts of special permissions to go into the hospitals to do the interviews, because obviously, because of the nature of the patients, I had to make sure that well, they weren't allowed to come out to be interviewed by me, so I went on to the wards. And I had some tricky times doing that, because I had some patients who wanted to be involved, who weren't allowed to be involved by their clinical team. So because I was somebody new going onto the ward, people were kind of gravitating towards me in terms of the patient group, and I had to say no to 1 or 2 people, which was, as an occupational therapist and being a person-centred person, I found difficult, but the clinical team had not agreed for them to be interviewed. So, So these are I'm not going to go through all my findings, because I think, you can, hopefully the slides will be available afterwards, and if you want to, contact me, please do. But you can see that all of the groups felt that there were implications relative to the diagnosis in terms of how people function from an occupational perspective. As you probably gather, there was lots to be spoken about in terms of theory of occupational therapy. These patients really valued occupational therapists. I was very surprised. I thought I might get lots of negative comments about people not giving them what they wanted and not giving them choices. But what they did say is that they really valued the occupational therapy sessions, and they really valued the relationship that they had. So again, it kind of comes back to some of the things that Ulrika was saying. It was about that value that they had in terms of our relationships, and that we were the people who gave choice, autonomy, opportunity. But what I did find really interesting was that they saw occupational therapy as a way of escaping from other therapies. So they saw it as a way of escaping from psychology sessions, for example, where people were asking them to bare their soul about some of the awful things that they might have done to other people. And they just needed some time out from that. They didn't mind that we were doing skill development. And one patient said to me, I don't know why you're getting involved in all that risk assessment stuff as occupational therapists. Just stick to your business and help me with things I want to do, which I thought was really an interesting thing, because as occupational therapists, we all think we should be moving into that psychological, deep and meaningful risk assessment stuff, whereas the patients are telling us, get on with your business. And that a lot of the patients were able to talk about how engaging in occupation was helping them create occupational lives and maybe think about different ways of going forward. So one man wanted to be a DJ and was doing lots of DJ activities. Some people were talking about work, and I'm going to come on to work in a bit more in a while. But the occupational therapists themselves were very mindful of the occupational deprivation that was relevant at the time. So I kind of did that, I completed that, and just as I was getting to the end of my PhD, myself and Mark Spivey, we did a survey where we wanted to listen to what forensic occupational therapists wanted from ourselves as a specialist section. So what did they want us to work on their behalf? And so we did a very quick and dirty survey. So we had a captured audience. We had 120 people at a conference a bit like this, and we gave them all a survey. Probably not the most ethical way to do it nowadays, but we got away with it at the time. And we got 68% response rate. And we were able to sort of look at a demographic profile in terms of what occupational therapy staff were. So they tended to be older, having worked in occupational therapy, forensic occupational therapy for 5 years or so. So we were kind of having information coming back from experienced practitioners. And what the practitioners wanted were research posts. Well, we don't have any in forensic OT, but what we have is lots of us who've done doctoral studies or master's projects now. What they really wanted was to be able to promote occupational therapy, because they felt that we were kind of way down the line in terms of being after the psychologists, the doctors, the nurses, and that we were kind of at the bottom. So they wanted something that would enable them to have their voice heard. And what they really wanted was some evidence-based practice guidance. So how am I doing for time? Okay. So what they really wanted was some practice-based guidance. And so that's what we set out to do. So a group of us got together and we were like, what is out there? Some of us knew what was out there, but some of us didn't. And so we had to come up with some kind of solution for this request from our community, really. And so 4 of us got together. So that was myself, Mandy Lang, Kath Mason, Rona McLeod, and Louise Llewellyn. And I think it's important to mention those people. And so what we were kind of thinking, well, what's out there? Where do we start even? So as a group, as a Forensic Forum, we approached the College of Occupational Therapists with a specific idea. So we can't, in the UK, I don't know if it's the same here, we can't just develop practice guidance. We have to ask permission from our professional body. And we had to put an idea together, and that was, they sent it back and said, do a bit more, and then we sent it back again. And so it was eventually accepted, and it was accepted as one of the pilot projects. So we had 18 months to come up with the guidance. We initially launched it in November, and it is NICE accredited, so that's the National Institute for Health and Social Care and Excellence. So it kind of has some weight, and we had to follow a very, very prescribed approach. We had a manual that we had to follow, and we couldn't step outside of the manual. So concerns and drivers for that. So why we were wanting to do it was we knew that there were limited opportunities for occupational engagement. Obviously, the impact of occupational deprivation on patients with forensic backgrounds, both historically and immediately within the environment, the constraints that we were under. And what we wanted to do was encourage people as practitioners to aim for that occupational enrichment. Oh, I'm going the wrong way. Sorry, I'm not as sophisticated as you, who had it off to a little T like that. So we used some of the statistics as well that were around. So the CQC is an official monitoring of hospitals within the UK, and they kind of look at how people are doing and what they're offering to patients. And as you can see from the statistics, most things were happening in the weekday, and most of the time it was from 9 o'clock in the morning to 5 o'clock in the afternoon. So the poor patients had nothing to do in the evenings and nothing to do in the weekends. And that's kind of not very normal in terms of everyday life. Certainly that wouldn't be how maybe you or I might do it. So we kind of use those to our advantages as well. So we had a core group which was led by Mandy and myself and the other occupational therapists that I've already mentioned. And what we wanted to do was our objective was to provide the evidence for the use of occupation, not for all the other psychological therapies. We did get some quite negative comments from some of the forensic community that we weren't talking about DBT and CBT and those, but what we wanted to focus on was, getting back to who we are as occupational therapists. We had lots of stakeholder and peer review, and we had lots of patient involvement. So we had to send the document and the guidance that we put together out. It went to people in Australia and various countries and various occupational therapists within the UK for comment. Our literature search, initially we had 4,000 hits, which was like, really? We didn't think there was anything out there at all. But after we did our data replication, our cleansing and our duplication and whatever, we got it down to 34 papers the first time round we did it. And we graded the evidence, but what I would say is the evidence is graded quite low because we didn't have any RCTs that we could draw upon, and which is something that we were mindful of. So the guidance themselves are applicable to each of the sort of security level of hospitals. We had to go through rigorous and critical appraisal of the evidence. So as a group, we had to do that in a very systematic way. We do think it reflects the core of occupational therapy. So it's occupation focus and it addresses occupational deprivation. And at the time, we based our recommendations on the model of human occupation. So I'm presuming some of you are familiar with that? Yeah? Because at the time, I'd had a group of research students who'd done a project who found out that at the time, most of the forensic occupational therapists in the UK were using that model. What I would say is that's changed now. There are some people that are using that model, but there are some people that are using the model of creative ability, which comes from South Africa, which I think is a great model myself, but I have to leave my professional opinions to one side for the moment. So I'm not going to read out loads and loads of recommendations, but these are the kind of things that we addressed. So in terms of volition, we were asking people to think of life histories of patients, about around the time of their offence, and how that influenced their occupational performance at the time, their life satisfaction, and their what we called criminogenic, so their criminal lifestyles. We were telling people to facilitate a range of interventions to engage, core OT stuff, structured daily routines, but actually that you expanded that across the sort of working, not just week, but you included weekends and evenings. Then we were really trying to encourage people to look at pre-vocational training and work opportunities. And I would say that pre-vocational and work opportunities in forensic settings has moved on considerably now. That is a core part of what occupational therapists do. And then, just in terms of the environmental considerations, we wanted people to consider the impact of the quality of life on people. I worked quite a lot with people who were in seclusion, who had nothing, absolutely nothing at all, and we couldn't take them out of seclusion because of the risk that they posed for other people. But what we want to do is encourage people to think creatively about what they might be able to offer. So I can think of one patient I worked with for 9 months who we had to seclude because he tried to kill a member of staff, and he was allowed nothing for 9 months in a room. And I don't know if you can imagine, and just reflect for a moment, what it must be like just to have a plastic bed, the clothes you have on that day, no other clothes, and that's it. You have nothing else. How de-stimulating that must be. He had to have 6 people to take him to the toilet, he had to have 6 people to take him to the shower, and he maybe got out for 10 minutes, 15 minutes of fresh air every day, but with 6 people. And so we wanted to get people to think, well, okay, yes, this man is a risk, and he was transferred to another hospital, but there must be something we can do for somebody like that person. We've had to review, so every practice guidance that is developed by what is now the Royal College is reviewed every 5 years. So we have just gone through the process of reviewing the evidence, thank you. And we had a new core group. What we've done this time is, and I can't show it to you because it doesn't work, unfortunately the link doesn't work, is that we have a patient version. So we have a film that we can show to patients based on the guidance, and we also have a leaflet that is based on the guidance, which is in, well, it's in better language than we're off. It's not so. The patients, when we asked them to review the document, said it was too full of technical language, and that they didn't really understand it. And there's lots of patients in secure settings who his educational abilities may not be what we want it to be or what it could be, and so we had to sort of adapt that. But the patient group, we asked lots of patients groups within the UK to bid for the possibility of doing this, and we were going to give them £1,000. And so one patient group won the contract, so to speak, and they developed the leaflet and the film. And I'm disappointed I can't show you either of them, because I think, all credit to that patient group. They have done an amazing piece of work that I feel a bit emotional, that I could not possibly have put together, but it is a really brilliant piece of work. And again, if any of you are interested, when I can, I could send links on. And that was funded by our specialist group. So as with all these kind of processes, there's need for more OT research and evidence. Risk assessment, models, I don't think we really need to do that now. I think that's kind of gone. But I think what we do need to think about is the impact of those occupations that we offer within the secure environments, and whether that makes a difference to whether people offend again when they're discharged. I think that's the really key piece of work that we need to be doing. We need to be thinking about our patients who have a learning disability, or when I've just come back from the Caribbean, and in Grenada they don't use things like disability. They use the term people of different abilities, which I think is a much nicer way of putting it. So people with different abilities, so patients in longer term, and we need to do much more about gender and our LGBT populations that we have. So I want to leave you, I know I must have 2 minutes now, have I? I want to leave you with these words, who are Sarah Markham, and she won't mind me saying this, was a service user. She, I'm not going to go into the details, but she reviewed our guidelines, and this is taken from what she said. She does write a lot more than what I've put up here, but I think it's really important that she talks about purposeful, positive purposeful activity is something everybody needs and enjoys. So all of us need that, but especially if you're a person in a secure setting. And in her experience, good occupation-focused practice can transform a patient's experience, either of their situation, so why they got to where they are, their sense of self, so their occupational identity, and a patient who is in recovery in the way that Ulrika's already explained to us, and as a human being. And I think those things to me are very powerful, what she says about our profession, or occupational therapists, or people who work in secure settings. So that is me. Any questions? Thank you.